Thank you, Ms. Lord. This is January 29th, 9:30, and as the chair, I'm calling the Prescription Drug Affordability Board to order. First and foremost is introductions, and also we need to establish a quorum. My name is Gary Merchant. I'm the chair of the Prescription Drug Affordability Board. I'm also a state rep representing Sullivan County District 6, which is Claremont and Croydon. To my left,
Todd Fahey.
Jason Azis.
Jess Edwards.
Kurt Williamson.
and to establish a quorum. At this point in time, we'll have to elevate you to a full member for the session only, Jason. No, we can't. Yes, I can. I think I said we get, because you're fine. Tom's on.
I'm sorry?
You're nominated by the governor, right? Okay, so we have one, so I can't. We don't, because delegates basically are based into either governor, House, or the Senate. So you're on the House side, since Todd's here, I can't. You're a full member, and I will elevate Tom Sherman, Dr. Sherman, from an alternate to a full because Senator Rosenwald is not here. So to establish a quorum, we have 1, 2, 3, we have 4. So we have a quorum. Thank you. In regards to the agenda review, is there anything people want to change, move around on the agenda at this point in time?
Okay, I'm really looking forward to talking about the redundancy report. And you had mentioned something prior to our getting started, Mr. Chair, about the fact that we don't have a draft before us already means we can't discuss it.
We can verbally discuss, but we cannot discuss a document. We cannot review a document. It's a document 7 days posted on the website.
Okay. All right. Thank you.
You're welcome. Is there any other questions about the agenda at this point in time? Hearing none, we'll move forward. Also, I'm very delighted to have today, it's been a long time coming, a gentleman to my right, who's now our executive director, Kurt Williamson. We went through an arduous process to find somebody. We went through a lot of interviews and so forth. I'm very delighted that you're here. Not the fact that you're coming from DC, which probably doesn't have a lot of snow, so welcome to snow country along the way. But with saying that, you have an extensive background, particularly a lot of things in this sphere of drug pricing, given the fact you've been with the NGA, National Government Association, also with Arnold Connections and so forth. So in saying that, do you want to introduce yourself and give us a few minutes to learn about you and what you've done and ask questions and go from there?
Absolutely. Yes. Good morning, everybody. I'm Kurt Williamson. Again, I just moved up from DC after nearly a decade. Thank you, Representative Merchant. That was very kind of you. And I thank the board members for all of your hard work thus far. I know it's not easy to get this passed, and I know it's not easy to stand up a government entity. So thank you for all of your hard work. I just want to say that out loud. So a bit about my background. I went to DC originally for my master's in public health. I got that at GW University. I then worked a little bit in the Senate. I was on the Finance Committee during the Cures 2.0 legislation when that passed. I then went and worked at the National Governors Association. I was there for about 2.5 years, where a part of my portfolio included prescription drug affordability and access. And so in that capacity, I led and executed a 50-state learning collaborative where we really focused on strategies at the state level to better balance access and affordability. Those are across markets, whether that's in Medicaid or whatever's under the state Department of Insurance's purview, what have you. And so it was at that time that we were starting to create the subscription model that came out of Louisiana. We saw the invention, and you all are living it now, of the PDABs. And so I was there on the ground level as these were being deliberated and developed. From NGA, I went to Duke Margolis, which is a think tank out of Duke University, housed within Duke University. It was there during COVID. So I worked on optimizing COVID vaccine distribution and ensuring equity in the process for all 50 states. So as you can see, much of my background has been in state government work. Most recently, I was at Arnold Ventures. Arnold Ventures is a philanthropy. It is dedicated to maximizing opportunity and minimizing injustice. In that role, I was the manager of the drug pricing and clinical trials portfolio. That is roughly a $90 million research and advocacy portfolio. We focused on what we saw as the main drivers of high drug prices, and where the market failures are. And so we would find anything from research and education to technical assistance and advocacy campaigns. I led a lot of the work as a subject matter expert on the advocacy side, helping to support and implement PDABs. I've been working on this issue for many, many years, but on the sidelines. And so I'm excited to learn from all of you to help bring relief to New Hampshire residents, New Hampshire families and patients. And so Gary wanted me to mention a little bit about my vision, and this is my first day, so as I'm sure it will evolve a bit. But as you all know, the pharmaceutical supply chain is exceedingly complex, and it's wrought with market failures. And I believe that with the growth of specialty medicines, cell and gene therapies, states are going to need to think fast, and they're going to need to think smartly about the impending budget constraints, about how are you going to make these products available at $1 million price tags while ensuring access, paying for roads, paying for teachers. And these are asynchronous. These launch at various times during the year. And as fiscal stewards, we need to protect the taxpayer, but also ensure that patients have access to those therapies, especially if it could be curative. We know that a lot of products are coming to market very quickly, often with little evidence to support their market access. And it's incumbent on us to make sure that we are reviewing the clinical evidence and that we're understanding what and the value for which we are paying for these drugs and whether or not that is reasonable for the state or for a Medicaid program. So I'll end with just briefly touching on the Stakeholder Advisory Council. I spoke a little bit with Tom about this earlier. I know this is a shared goal of all of you and it's a priority. As you all know, under RSA 126, we are directed to establish a Stakeholder Advisory Council. It's a 12-member advisory council. It's very prescriptive, but we wanted to let you know that we will start sending out those letters to each department, to each entity, letting them know that either the presiding officer or their designate can serve in this capacity. As for timing, we intend over the next few months to get this Stakeholder Advisory Council in place. And we will keep you all updated as we know more. I saw that Tom was able to join. Tom, did I miss anything or is that good?
No, I think that's pretty thorough. The idea is that we want to have the advisory council up and running in time for any recommendations that we as a board put forward. So that's really the goal, so that we can then turn to the advisory council for the advice that they'll provide. So we need to, we are reaching out. We actually will be drafting the letters. I'll be making appointments to meet with people who could be on there just to answer any questions or concerns they might have. And Kirk and I will be following up on that with the goal of having it up and running in the next couple of months so it can be successful in its role in advising the board.
Awesome. Thank you, Tom. So I'll pause there. Welcome any questions or comments. And if not, we can proceed with the agenda.
Well, thank you for that.
Yeah.
And also welcome aboard.
Thank you.
We're wasting one. So any questions for Kurt at this point in time as far as his background is?
This time, welcome.
Awesome. Thank
Glad
you.
to have you.
Questions?
No.
No? Any questions?
Thank you.
Tom, any questions? Oh, I see Dr. Woodward. Bob, you're here as well. I don't know if you actually caught Kurt's introduction or not.
I caught a piece of it at the end there.
Yeah, okay. I like the fireplace, by the way. So, all right, moving forward to that, I would like to move on to the agenda, onto minutes, if you will. In your packet, you have both the October 30th, we have not approved them yet, and the other one was December 18th. Take the one for October 30th. If you look at October 30th, I have a recommendation to this board to modify the minutes, reflect what was discussed at that meeting. If you look into the minutes before you, it's in gray. We had a discussion, Representative Edwards supported having a 3 to 4 year for the executive director, and also striking the requirement for the joint fiscal committee review of the contract if it's not a state standard. And also the board basically supports the intent of all three SRs. So that's my recommendation to the board to revise the minutes.
So is there discussion on that?
You can have yes, sir.
I did support it, but you know, if we want to put the context in here, what I said first was I don't really want to change the executive director term until after the redundancy report has been completed. I made that point very strongly, and listening to the board and trying to be a team player, I allowed myself to feel peer pressure, which at my age I shouldn't, but I think I went along with, you know, kind of the sense of the board. But as I thought about it later, I returned to my original position, which is I do not want to be making substantive changes to this board till we get the redundancy report in and reviewed.
I believe that was captured if you look at the line before that.
So I don't believe that this captures it, contextually. And if you're going to make this change here, I want the minutes today to reflect my very strong opposition to making any substantial change to this board until after we've had a chance to review the redundancy report.
That's fine, but to go back to what you mentioned before, the concern you had about the redundancy was actually captured in the minutes. So if you look at the first two lines before.
So you're not listening to me. You can go ahead and force this in there, you know, over my opposition. But I'm just going to be clear that I really don't care to have the minutes gamed like this.
The minutes are taken off from the actual tape, if you wish to go back and look at it. So the minutes have to reflect what was said, not what was after the fact.
Mr. Chair.
I think there's great art in writing minutes, and I don't care the way this is getting done.
Tom?
Yeah, just the point that Representative Edwards just made is that he wants today's minutes, which they should, to reflect how, you know, in what he said that day is captured in the minutes. The way, and it sounds like it was captured with some of the caveats, but not the full caveat that he doesn't agree with that now. But today's minutes will capture that.
Yes.
So that's the timeline, that minutes have to reflect the meeting at hand, whether it's the meeting in October or the meeting now. So, you know, just to reassure the representative that his sentiments will be fully captured in the minutes, that is the way meetings are, you know, that's the way they work. And
Yeah,
I agree with
really don't need that education, Dr. Sherman. I sort of resent it, actually. I think if you were to just change this from supports 3 or 4 years to supported, I'd be okay with that change. Because at the time I did support it over my better judgment and today's judgment.
Grammatically, by taking the word supports to making it a,
Supported. I'd be fine with that.
I don't know if grammatically.
Because at that point, I was convinced by the peer pressure to go ahead and join with you. But I really want to stick to what I said initially, which is we said we would do a redundancy report, and we would take a look at a redundancy report and figure out what the right thing to do is with this board. That's what I've been saying consistently.
I think that was captured again in the line before that, but right now change the word supports. I'm open to it, but I don't know what word. I'm not an English major.
Supported, from supports
It
to
doesn't read
supported.
correctly. Supported, supports.
Representative Edwards supported 3 or 4 years. That's a sentence.
I think if there's to the extent there's any dispute over the minutes, we probably need to take it up with the DOJ and have them I'll weigh in.
I don't want to go to the DOJ. That's ridiculous. Let's just make a decision and move.
Motion to approve the minutes
Thank
with a connection, with a correction to changing supports to supported. And also noting Representative Edwards' position today at variance with his position when that vote was taken.
Thank you. Have a second, please.
Second,
This is because we're doing a virtual meeting, we have to do a roll call and all motions, so I'll call the roll call. Todd Fahey,
Aye.
Jess Edwards,
approved.
Tom Sherman.
Yep.
Chair votes yes, 4-0. The other one we have is, thank you.
Mr. Chairman, I'll just abstain from the vote. I signed in a little late,
Oh,
but I wasn't there
that's
for
it.
last meeting. So,
Oh,
and excuse my appearance. I have my kid home from school today.
oh, no. Thank you, Senator. Okay, on the December 18th minutes, a motion to approve the minutes. Or is there any changes for discussion?
Move to approve the minutes.
Second,
Second.
seconded by Todd Fahey. Again, roll call. Mr. Fahey,
Yes.
Tom Sherman,
Yes.
Senator Abbott,
To approve the minutes, I abstain again. I wasn't here at the last meeting, so.
thank you. And Mr. Edwards,
I abstain.
and Chair votes yes, so it's 3-0. That passes. Now on to the presentation by PCMA. I think it's Johnny Garcia. City Roosevelt is here as well. Senator Roosevelt. Is,
They should be able to speak if they take themselves off mute.
okay, so they're on the panelist list, right?
Nancy, how do I verify that?
What's the question?
Is Senator Abbott and Senator Roosevelt on the panelist list? I see Senator Abbott, but I don't see Senator
Yeah,
Roosevelt.
Senator Roosevelt is not.
He
It's
attended?
not. I don't know why Abbas's name came up as Rosenwald, but I just changed it. Both
Oh,
were
okay.
Yeah, I
invited.
did see
All
that
right.
too.
Both
Okay,
were invited, only Abbas is here.
okay,
Senator
Thank you.
Roosevelt will find that very offensive that you,
Oh, okay. Interesting, yeah.
okay.
I'll defend
thank
her.
you. Okay, thanks, Joe. So in regards to the presentation today, white bagging, the reason why we're having PCMA today was at one of the meetings, I believe it was in October, we had a discussion about white bagging, and in fairness to PCMA, I wanted them to have an opportunity to present their side of the story. So this is their opportunity, Mr. Garcia, or Dr. Garcia, to present white bagging from PCMA's point of view. So take it away.
Yep. Good morning, Chairman and members of the board. Johnny Garcia, I'm a pharmacist by trade, 23 years experience. I've worked in specialty, retail, mail order, and now working for the PBM. So kind of been all over in the industry, but did want to talk a little bit about white bagging. Do I have screen share capabilities for the presentation? Okay. Give me just 1 minute to pull up a presentation here.
So Mr. Garcia,
Sure.
I'm relatively new to the pharmaceutical industry. Would you make sure that we understand before you get started what PCMA is and what sort of advocacy positions PCMA is known to take?
Yes, sir. So PCMA is the acronym for the Pharmaceutical Care Management Association. We're a national association that represents about 40-some PBMs, and PBMs such as CVS, Express Scripts, Optum, Prime Therapeutics. There's a whole bunch of others, Humana, Elixir. I can keep going. But our position is to ensure drug affordability for patients and our clients. So we're often looking at ways to reduce drug costs within the supply chain. So we interact with drug manufacturers, working on price concessions to reduce the prices of drugs. we work with our plans. So those are the major health insurers and represent their portion of the pharmacy benefit design. And then we also represent some of the employers out there as well. They do directly contract with us to manage their prescription benefits. So does that kind of answer your question of who we are and what we do?
Yes, thank you.
Sure thing. All right, can you all see the presentation?
Yes.
Okay.
Hold on. Yes.
Just one more. Are you a 501c4 or C6?
You know what? My colleague Sam is in the room. I don't know if he knows. I don't have that information off the top of my head, but I could get it for you.
Okay, thank you.
Mr. Garcia, you may want to change the presentation. Right now we have. So you can take the full screen.
Oh, okay. Let me try this. I do apologize.
It's okay.
Are you able to see a blank screen or are you seeing the presentation?
You see in a presentation, but on the left-hand side, we also have all the other slides.
I think if you go to the slideshow tab, I think.
I apologize. I'm better with Teams than I am with Zoom here, so.
I can feel your pain because when I get on Teams, I don't know how to work Teams.
Yeah, I've
Go to,
better there.
go to slide,
On
on
the
the top slideshow.
Slideshow, top line, under white bagging.
Can you see my mouse cursor?
No, I cannot.
Oh,
Right
okay.
there. Oh, you just had it.
Well, that's me. I was trying to point it out for him, sorry.
Okay.
There you go.
There you go. Yeah.
That's fine.
Are we good?
We're good.
Okay, I apologize. Definitely not. My degree is not in technology, it is in pharmacy, so I definitely apologize. Okay, so let me back up a little bit here and talk about what white bagging is. So white bagging is physician administered drugs. These are drugs that require some kind of formulation before they're administered through either IV or injectable. And those are prescriptions that a healthcare provider has to provide to the patient. So these are either done either in a hospital setting or an outpatient setting. So either an outpatient clinic or in the hospital, sometimes in the provider's office. So white bagging is when a specialty pharmacy, so a separate pharmacy from the hospital, delivers a patient-specific medication directly to the provider for administration. And then these physician-administered drugs are often high-priced. They represent a growing share of all prescription drug spending nationally. When we talk about high price, some of these medications can be anywhere from $10,000 up to the $500,000 mark. So they are very expensive per dose. The way that the process works is the prescription is sent to the specialty pharmacy by the provider. So they are contracted with a pharmacy to send these drugs out. The pharmacy gathers the information to fill the prescription, including and coordinating all appointments and care plans. And then the prescription is sent directly to the provider. So behind the scenes, what's going on in a specialty pharmacy is there's a lot of processes. So it's not a typical standalone retail pharmacy, your mom and pop shop on the corner, the Walgreens on the corner. These are very sophisticated pharmacies that do a lot more to ensure patient safety and cost. So the initial prescription is received from the prescriber, and it goes through a cost evaluation, which is called benefit verification. So benefit verification, the pharmacy will look at that prescription and the patient's insurance plan and determine what is the most cost-effective way to bill this. If the insurance plan has determined that this drug should be covered through a medical plan, it'll go through the medical plan at that time. If it's to go through the pharmacy plan, it'll go through the pharmacy plan at that time. So everything is conducted up front before the prescription is actually filled, just to make sure that the medication can be affordable for the patient. So after all that information is obtained for the cost and how the patient is going to be paying for this, it goes through an initial clinical assessment. So this is a team of highly specialized pharmacists, technicians, nurses, doctors that review the medication and ensure it's safe for the patient. So there's a lot of checks that go into this, such as ensuring it's the right drug based on the patient's weight, that we have the right lab values in place to ensure the patient is safe to use the medication, and a whole bunch of other checks in there as well. So any information that is missing is then obtained from the provider. So the pharmacy will reach back out to the provider to obtain that information, making sure that we have the full prescription and package together before it's processed. So after all that is completed and it's deemed safe for the patient to take, it goes through a care coordination. And the care coordination is not only with a provider ensuring that the medication arrives on time, but also with any other support and education that needs to go out to the patient. So sometimes some of these patients may have a social issue, they may have problems getting to work, they may have employment issues, things like that. So at that time, anything that's related to their healthcare is coordinated at that time. And then at that point, it moves on to the education portion. So this is where the pharmacy will reach out to the patient, start going through the plan, making sure it sounds correct, making sure that they can understand what's to be expected, how the medication is going to arrive, ensuring that the date of the administration has not changed, things like that. And a lot of that is done with the patient at that point. Answering questions, the patient has access to a pharmacist 24 hours a day, 7 days a week. And then after all of that is done, the medication moves on to the dispensing and distribution portion. So that's where it's processed in a very sophisticated system, making sure that the patient receives all the tools and supplies that they need to administer the medication if needed. So syringes, cotton ball swabs, all that kind of stuff is all packaged at that time at the dispensing and distribution portion. And then after it's done and ready, it moves on to billing. So we've already obtained the billing information from the patient, but it is the very last step where we will charge their credit card or ask how they're going to be paying for the medication. So any questions on this before I continue on?
I have some questions.
Good.
Thank you, Mr. Chair. As I'm looking at this, I'm trying to understand the organizational structure that stands behind all of these processes. Is this one organization? Is this a PBM by name somewhere that's doing this, or is this actually a cross-section of multiple entities being coordinated across organizational boundaries?
So this would be a
Is this
special.
one company or something else?
This would be the standard process amongst any specialty pharmacy that's owned by a PBM. So this could be a CVS, this could be an Express Scripts, it could be an Optum pharmacy. So they all go through this process. It's very standard and it's accredited by national standardizations.
Okay, so I'm trying to focus on making sure I understand the organization. I understand the process. It's right there. But what I think I just heard you say is that this is going to actually be taken over by a single PBM to execute this order.
This would be done at the specialty pharmacy. So specialty pharmacies are typically owned by a PBM. Not all, but a lot of them are. And so this process occurs in that specialty pharmacy.
Okay, so all the costs of this process are borne by an entity that also does the billing and collecting.
Yes, sir.
So if I may, Mr. Garcia, in regards to the clinical assessments and clinical care coordination and so forth, isn't that kind of redundancy to what the physician is doing at the clinic to begin with?
It is, but it's part of what the pharmacists are going to need to do the clinical evaluation for the medication. So just like a retail pharmacy, they do a drug utilization review. This would be our version of the drug utilization review for specialty drugs, making sure that we have all the proper lab values and making sure the patient is still safe to take the medication. So those are things that the doctor should be able to provide to a pharmacist, just like any other prescription.
One of the things that I've been hearing about is redundancy and the cost of redundancy. So why are we paying for more redundancy?
This is part of a pharmacist's responsibility based on their licensure. They have to ensure that it's safe for a patient to take. So this is just something that is part of regulations and standard practice.
So in effect, there's 3 safety checks. There's 2 on this process, and then the ordering physician is also doing their own, right? So is that basically true, that there are 3 safety checks involved?
Depending on the level of safety check, I mean, a pharmacist is more responsible for ensuring that there's no drug interactions with the medication. The doctor is typically responsible for the diagnosing and ensuring that the medication is appropriate for that patient's therapy.
So even though the word safety is associated with it, the view is slightly different based on who's looking at it.
Yes, sir. I would agree with that.
Okay. So that would be complementary, not redundant, I think. But that's just parsing words.
Thank you. Let's move on.
All right, so the medications that go out, oftentimes we're hearing that these medications show up at a person's doorstep or to the doctor's office without any, safety checks or any quality, that they're arriving in highly, high temperatures or whatever the case may be. These medications that at least have temperature sensitivity are packaged in a third-party approved technology. So cold chain technology is the actual name of the product. So these are lab tested, tried and true methods of shipping the products out. So they come through in a styrofoam cooler. There's multiple layers that go into this to ensure the product is either not frozen or gets warm. So we have to worry about both of those, right? If we're putting a cold pack into these, a frozen gel pack or something like that, it can't touch a product, it'll freeze it. So there's a lot of layers that go into this to ensure that the product stays at that temperature. Cold chain technology is used by many specialty pharmacies because they've been shown to get the products there safely. They can test extreme temperatures, setting to Minnesota in the -30 degrees down to Phoenix where it's 120 degrees. These packages are tested for all of that. So these medications arrive to a physician office or to a patient's home more safe than they come from a wholesaler. And anybody who's worked in pharmacy has received the totes with drugs and just cold packs thrown in it. These are way more sophisticated than that process. So this is just a little diagram kind of showing what it looks like. It's layered like this. These are things that are also go through the accreditation process to ensure that they're consistent and that the products will arrive safely. So any questions on this slide?
Yes. I have one. Having worked in the hospital pharmacy for several years and working with wholesalers, I am well aware of the fact that wholesalers today use the same technology to ship biologics. It's really no different than what you're using here for specialty pharmacy. I don't know, maybe some time ago it was, but today, the technology that you're referring to is used by the wholesale as well as by the specialty pharmacy. Number two, what happens when there's a broken in a cold chain? In other words, we've had times in which product received at the pharmacy level, even though it's packed correctly and so forth, sometimes they're not packed correctly and cold chain's broken. And therefore we have product that we can't utilize because it wasn't shipped correctly. But because we have the inventory on site, we have product to allow the clinician to use something. If the clinician at the clinic is relying upon this to come in and that product is therefore not shipped correctly, how do we deal with the provider who all of a sudden has a patient showing up, but the drug's not available to them because it wasn't shipped correctly? How does that impact the patient care and also the physician?
There's multiple avenues that we could use for those types of patients in those scenarios. So they are far and few between, but if a product is arrived damaged or not usable, the prescriber can either reach back out to the specialty pharmacy and arrange for either a same-day courier service to have that delivered directly to the provider for administration. If the hospital is using the buy and bill process, which we'll get to in a bit, they could use their stock of the medication and bill the medical insurance for that product, so there's no delays in therapies. Or if the patient can wait, which is not optimal, but if the patient can wait, then a new product could be shipped through the mail order service next day.
So if I hear it correctly, again, back to the redundancy, the specialty pharmacy is relying upon the clinic to have its own inventory under a buy and bill scenario, which is redundant to what you're talking about here. So again, back to redundancy. And number two, when the patient's inconvenient, as well as the provider, if you will, how do we compensate them for their time?
Well, they would be billed through the medical benefit, and we're not, and just to back up, we're not relying on the clinic to have their own supply. That's just an option. If the pharmacist, if the doctor has it, they absolutely can use it. But the specialty pharmacies do have in-network pharmacies located close by or within driving distance that they can obtain the medication from and have it couriered directly to the doctor's office. So the doctors would bill this just like any other administration.
Okay, thank you.
Mr. Chair,
Yes.
quick question. I have almost never seen that swap go smoothly when the drug is not available and the patient is there and the clinic can administer, does the prior authorization for the shipped product from the PBM extend to the insurance company that will be billed for the product because the PBM did not ship it because it was damaged in shipping? In other words, what you're saying is that if the patient is there, the product is there, or the medication is there, the provider can go ahead and administer it, but they would be billing the insurance company correctly. Wouldn't they have to go through a separate prior auth process to bill the insurance directly, or would the prior auth process that the PBM just completed and approved, would that suffice for the insurance company?
That does vary by PBM and by the plan. So those that do process the PBM or the prior authorization at the PBM level may have that information contained separately from the health plan. There are other health plans who do their own prior authorizations, and in that case, the prior authorization would carry over for the medical plan as well.
So there's a possibility, if I might follow up, there's a possibility that the drug not available because there was damage in shipping or something like that, that the patient is there, the drug, another drug is there, or the same product is there, but it can't be used because there's a separate prior auth process that has to be done with the insurance carrier.
There is a possibility, yes. So oftentimes the information is relayed back to the plan since they're the ones paying for the medication, but there is a possibility the prior authorization does not transfer over. Yes, that is correct.
Okay, thanks.
So, Mr. Garcia, I think what keeps getting touched on is the the probability of logistical success on a specialty order. Are we talking about, 80% of the orders actually get delivered as expected and get delivered to the patient? Or are we talking 98%? Do we have any supply chain statistics to tell us how reliable this order system is on a first-time order basis?
I don't have that data readily available. I can absolutely get it for you. Given the amount of plans that are adopting this policy, one for the cost and also for the ability to get the product there safely, I would guess and venture that it's higher than the 90% success rate than it is on the lower end.
Okay, I would imagine those stats are kept somewhere because that's critical to your profitability and your insurance premiums. And I assume you have insurance premiums that you guys also pay to help cover any costs associated with a failed shipment, or are you self-insured?
Yes, no, we would have processes for a damaged product that's mailed through shipping. So that would be usually through the carrier service, UPS, FedEx, whomever's used.
Okay, so I'm not going to ask you for those shipping statistics, but it seems like there are folks on the board that may be interested in them, but I won't make the request.
Okay, if it's something that the board would like to have, please reach out and we will try to get those for you.
Thank you. Next slide.
Okay, so the last slide that I have here is just an example of the pricing of some of these products. So this is for CAR T therapies. This is from 2021, and this is from a well-known, reputable resource. So hospitals prefer the buy and bill process, which is what we were talking about. A doctor would go into their personal supply, administer the drug, and then bill the insurance separately through a process called buy and bill. It would be typically at a higher reimbursement rate. In this example here, these are 3 different drugs, but the column in blue is a charge master price. That's the price that the hospital would charge an insurance for. The price in orange is what the wholesale acquisition cost is, and that's a little bit more close to what a specialty pharmacy would obtain the medication for. And then the green bar is an example of where the insurance company negotiates with the hospital for reimbursement. So on the very first example here for the Yescarta, the hospital would bill the insurance through buy and bill at $75. The negotiated rate would be somewhere down in the $870 range. And if it had been dispensed through pharmacy, a specialty pharmacy, it would have been probably around $400 or a little bit less, depending on the contract with that pharmacy. So, and this is a pretty consistent example of what goes on the billing side of things and why specialty pharmacies are more preferred. They are more cost advantageous, and should a product even get damaged and is not usable, and we were not obtain any reimbursement for that product, we could still dispense that product twice for the price that we got it for from the negotiated rate. Any questions on this slide?
Yeah. Yeah, I'm sort of asking you a question, maybe Dr. Woodward would be interested in this, but from a health economics perspective, if white bagging were to go away, what would be the best guess on future price trajectories? Would we tend to think that the economics of this is that if white bagging was not an option, that overall costs through the other options would be reduced or not?
I think that's the market would need to play itself out. If I had to guess, I would say that the cost would continue to go up. If the medical plan is having to pay for these drugs and they are paying 3 to 4 times, sometimes even 6 times if it's a 340B entity, the price that the drug was obtained at, those are going to get tacked onto premiums. So it may not be through the patient's out of pocket for the pharmacy spend, but it will show up on the premium side because they're going to have to go up. And we're starting to see that play out in the marketplace with some other medications out there right now that are, increasing specialty spend, and premiums are going up in specific states.
So then would it be fair and accurate to say that white bagging, even if it does not meet the clinical objectives at all times, is probably nevertheless an important element of the market to help maintain price discipline?
Yes, sir. I would agree with that. And I would say that if the board is considering those one-off scenarios or those emergency type situations, focus on that. This is definitely not a one-size-fits-all. White bagging practices are definitely necessary to control specialty drug spending. There are going to be occasions where we probably need to look at those emergency situations a little bit more closely, and what are the processes for those. If the product is damaged, if a patient's dose change is made that same day, what are those processes and how do we improve those?
So another follow-up.
Good.
Okay, so because you just mentioned the possibility of looking to fine tune processes, and I think I heard you say earlier that there is a panel or a board or some group that reviews these processes and basically has approved them or put their professional credibility behind the processes. Are you saying that that same group would need to be reconvened to look at some fine tuning possibly around the exceptions case?
Yeah, I believe that's a valid statement. So the accreditation process, which is a third party entity, they do review that pharmacies have processes in place for shipping products that are damaged or delayed. They ensure that portion of it, but there may be a gap. I mean, from what I'm hearing from Dr. Sherman, I believe it was, that there are some issues possibly with the prior authorization transferring over. So that might be a gap that we would need to look at.
Thank you. Thank you, Mr. Chair.
Mr. Garcia, I noticed on this slide, the reference point is the hospital charge master, and having worked in the hospital for several years, the hospital charge master prices, quote, list price. That's what they have to put on the charge master for the CMS cost report. It doesn't really talk about what is reimbursed to the hospital, the negotiated price. The negotiated price is totally different than the hospital charge master. So are we comparing apples to apples, or are we comparing apples to radishes?
No, I believe this is accurate. I think, a lot of the drug supply chain uses list price as a basis. And if the hospital is sending that over to the insurance company for reimbursement, they're asking for the highest level, and then that gets reimbursed at a different level based on the negotiations that go on back and forth.
Would the hospital beg to differ, because the hospital transparency, which is prior to the national level, also at the state level, I can go in and see that the actual negotiated price is far different than the list price. So I just want to be sure that when we're looking at data, we're looking at it through the lens that's looking at price to price. So I would look at that and saying that the charge master, what you're saying, but I'm trying to make the argument that it's really kind of a misnomer because it's really not what's ultimately paid. The other one, wholesale acquisition cost, if that's going through the specialty pharmacy, that's again a list price. We don't talk about the net price that the PBM is going to have after rebates. So we're almost on one side talking about the hospital on their list price. We want to use that versus their net price, which is what is paid by the insurance company or paid to the insurance company. Same thing on the wholesale acquisition cost. That's a list price, but that may not be the net price after rebates. So I hear what you're saying, but I think the data is somewhat skewed, or potentially could be skewed.
Yeah, and Mr. Chairman, if I may, there's also 340B drugs, right? These drugs are typically 340B. So if we're going to talk about discounts for the specialty pharmacy and the PBM, there are going to be discounts for a hospital as well through the 340B program. Oftentimes, the hospitals pay half the price for these drugs, which is by far the biggest discount out in the market.
Understood. The other question I have for you, as far as looking maybe for questions, when we look at the overall cost shift, because also with Doug Channels, I can pull something up for you, Mr. Garcia, as well, that the actual cost savings is not so much the insurance company, it's being shifting the cost from the insurance company to the patient. So the patient's out-of-pocket cost goes up significantly to drive the cost down to the insurance company. So we're reducing the insurance company's cost by creating the patient pay more for it out of pocket.
If it's going through the pharmacy benefit, that is correct. So the patient would be responsible in a high deductible health plan setting for paying their deductible. If the patient has a better health plan provided by their employer, they would have a set copay. So that may or may not be there. I think the other piece that's possibly missing is how much of the surprise billing occurs at the patient level, where a hospital may try to recoup some of their costs and send a bill to the patient. I understand that some of the surprise billing has changed a little bit and there are certain limitations, but I do not believe drugs are part of that exclusion list.
So we're shifting the drugs from the medical benefit or the pharmacy benefit fundamentally.
Depends on the plan's design. Some choose to do it through the medical benefit, some choose to do it through the pharmacy benefit, and others prefer that they have a location that administers these medications that are negotiated rates. So if my suggestion to the board would be to look at policies that require hospitals to use or to negotiate prices up front so that there's no hidden costs anywhere.
But would that be what the insurance company can do now? They can negotiate with the hospital. It's a free market.
They could, absolutely. If the hospital is willing to accept the terms and conditions of the health insurer, then absolutely a contract could be created.
And also, if I understand, earlier in the slide, you mentioned about the PBMs, that a lot of the specialty pharmacies are owned by the PBMs. So therefore, if we're shifting from the medical side, from the provider over to the pharmacy, which is owned by the PBMs, are we doing a lot of self-referrals?
Self-referrals, not typically, no. I mean, it depends on how the plans are designed. Not all, there are some health plans that do not use the same PBMs, specialty pharmacy, to provide the services. There is kind of a mix and match, if you will, an a la carte type process out there where they can pick and choose which specialty pharmacies they prefer based on pricing and their population.
Wouldn't that be mostly developed by the plan, if you will, for the prescription drugs themselves? And what I'm trying to get to is a conflict. I think it's a conflict of interest where I'm now asking the patient to go to a pharmacy that PBM that I own, basically. At the same time, when I do that, I'm going to ask the patient to pay more out of pocket.
Yeah, I disagree. We've seen this play out in California, where California Blue Cross Blue Shield recently created their own a la carte. They're using a health plan for one benefit, pharmacy for a different benefit, and then they have somebody processing their claims through a separate person. So they've kind of created their own a la carte. It's definitely the free market at play, and I believe that is still available to anybody out there.
Following up on your comment about California, I think California, what they did was to break the market apart so that we have not just one entity, which I think what Representative Edwards was talking about before, instead of having one entity, we actually have broken it apart into different segments and allowing the market themselves, because it's not all in one company, but you have different pieces of it in different companies to allow the free market to operate the way it should work.
Yes, sir.
Thank you.
So, go ahead.
Well, to follow up on your point about a conflict of interest, so we're talking about the PBM owning a specialty pharmacy in which they are bypassing the normal distribution channels. So they're bypassing negotiating with wholesalers and distributors. They are taking the drug and they are negotiating the rebate. So the PBM is dictating the reimbursement and they're also capturing the rebates in this scenario, correct?
In this scenario, they would be capturing rebates if it is a drug that is preferred. Yes, that would be correct. But that would be something that's preferred on the health plan. The rebates don't trickle down into the pharmacy. The pharmacy is still paying for those. The rebates are often passed back to the plan and used by the plan to keep costs down.
Which is the PBM that owns the specialty pharmacy.
The PBM typically owns a specialty pharmacy. Not all plans own a PBM, though.
Right. Okay, thank you.
So, yeah. Okay, so I used to work in radiology. In radiology, we had the Stark Act over us for decades, which basically said that physicians couldn't own their own radiology equipment that they referred out to, and therefore controlled the patient and the billing and all of that. And that kind of made sense to me after a decade or two. And so I'm hearing pieces of that potentially here, is that we might want, maybe nationally, New Hampshire's pretty small, but this idea that a specialty order might get controlled to the point to where it becomes exempt from competition, that could be problematic. And so for me to understand this, I would need to see more diagramming, you know, control of the order, control of the money. You know, this, just hearing this and seeing this is just a bit much for me, but my instinct is that there may be a potential problem in the way the order is controlled.
One last question, Mr. Garcia, if I could. When it goes to the pharmacy benefit, at that point in time, the patient pays for it, and it shows up to the provider and they can't use it, who's paying that? And again, it may not be able to use it because of the cold chain technology, but what happens when the therapy has to be changed? I, again, work in clinics many times. I mean, patient comes in, you do the blood work, you look at it, and all of a sudden you go, it's not working, I need to change the therapy to something else because it's just not being effective for you as the provider looks at the blood works, looks at the results and the symptoms and so forth that the patient presents with. And the provider has to change the therapy, or sometimes the therapy has to go up or go down. So at that point in time, when those changes occur and the patient's paid for it, how do we reimburse the patient if they can't use the drug, but they've already paid for it?
Yeah, so there's a lot of there's a lot behind the scenes. That's kind of a bag of worms, if you will. Their value-based contracts are really important in the PBM industry. The product is not working. So in your first example, if the patient's blood work is not working or is not changing and they're not receiving optimal therapy and the doctor has to make that change, that's where the value-based contracts come into play. And those are contracts with the PBM and the drug manufacturer that limit the exposure to the patient and the plan for products that are not working. So why would you buy a car that's not working correctly? That's where the lemon laws are out there. And that's kind of a similar type of method here with the drug products. Now, if a drug has to be changed at the same day by the dose, we would repeat that process of either the doctor would use their supply and then bill the insurance for that. Behind the scenes, there's going to be a lot of approvals that have to go through, and the question of why the patient received 2 doses of the medication is going to come up, because in our books, the patient received the medication from the product that was sent out, but the doctor is going to have to inform the pharmacy that the product was damaged and therefore they're going to need an override. So the patient should only pay one time. The plan and the pharmacy will eat the cost for the damaged product if we can't recoup any of the cost back.
Thank you. I'd like to have more information about that, if you don't mind.
Okay, which the part about the patient
Yeah.
payment and paying one time?
Correct.
Okay.
What my concern is the patient not getting caught where all of a sudden the drug's been shipped, they paid for it through the co-pays, whatever else they have to do with a credit card, they whip it out and all of a sudden they pay you $300 for something, they get to the doctor and the doctor says they can't use the therapy because it's changed for whatever reason, but they paid $300. And by the way, here's another one, it's gonna cost you another $300. I want to be sure the patient is not at the point of having to pay twice.
Yes, sir.
That's
I'll
what-
get you some information on that. We do have override codes that we use for damaged products or products that are lost,
Mr.
whatever
Chair,
it may be.
comment on that? I appreciate the concern on that. I think the state and federal governments have medical bill and fraud statutes in place to protect against that. Because if the billing entity is a hospital that bills a patient twice for one service, that would constitute medical bill and fraud.
In this case, I'm just saying, just what happens is you went from drug A to drug B. So it's not a duplication.
But if the drug was not administered, then the first bill would be reversed.
That's what I want to be sure.
Well, that would be a point for education. It's important to note, I think, that these drugs now are so expensive and they have high cost utility. They're displacing surgeries in lots of cases. And so I look at this very similarly to where a patient comes to a hospital for surgery and they can't operate because of some alteration in their clinical condition and get sent home, and then 2 weeks later they come back. They're not going to be charged bill for any services related to that. So I think we should consider these drugs, given their cost, but also their clinical utility, in a whole different realm. And that's probably something that is going to come with part of the specialty drug movement forward.
And that's what I want. It's a good point. I don't disagree with you. I just want to be sure that somehow as we transition from this one to this one, that the patient doesn't get lost in the shuffle.
Sure. Heightened responsibility on provider and hospital communities, I think is the key point there.
As well as the specialty pharmacy.
So asking the experts on this on the board, when a person purchases a drug, the manufacturer, let's say there's drug A and drug B, and you don't exactly know what the efficacy is going to be as applied to any particular patient. And there's no, I presume that there's no warranty from the seller that the drug manufacturer that this is going to cure, right? I mean, so then if that's the case and you have to change the clinical course with the patient, and I don't think this wouldn't be a fraud situation because it's a clinical change. How then do you hold somebody responsible for the change in course without a representation from the manufacturer that this particular drug is going to cure your ill, for lack of a better word? That's what I'm confused about.
Yeah, it's complex, certainly, and the clinical status of a patient for that condition of interest is assessed consistently prior to surgery and lots of other medical interventions. Now, including more and more with specialty drug administration, these drugs now are identifying genetic targets that are like no other therapy that our system is really used to. So clinical models need to change to be more attuned to that, and the site of delivery and the site of therapy and the site of service bears a great responsibility for these new drugs that are doing great things for our population.
So in fairness, like we're talking about drugs that have a fairly expensive price tag because of, what was the word you used when you can use a pharmaceutical in lieu of a surgery? What did you call that?
They're displacing much more invasive, oftentimes, in my opinion, sometimes barbaric surgeries. They're displacing scalpels and many times saving lives.
So when they're displacing of scalpels, we're not talking about a drug that's costing hundreds. We're talking thousands or tens of thousands, or potentially hundreds of thousands per administration.
Sure. We see drugs. There's one drug in our new high-cost drug dashboard. There's $2.2 million for one dose. So we need to start thinking about drugs as things we open from a pill bottle, put in our mouth or inject under our skin, rather medical interventions that are opening up a whole new frontier of healthcare.
So I think,
So-
I'm sorry.
So just one, let me finish. One thing is that the marginal administrative cost, the administrative cost for each delivery of 1 unit of that drug is really small when you look at the overall cost and utility of those therapies.
Sure.
Even though from our, from our standpoint, it looks like a lot because we think about it in terms of giving somebody an aspirin, now we have to do all these safeguards. They're not tantamount to that. They're much more complex and have much higher utilities to our population.
So excellent. And just one more thing, if I may, and then I'll stop. I think it's very important for us on this board to make this intelligible to the people legislating on the issue who don't have the sophistication that all of you, for the public generally, and for people even watching. So we understand what's happening because there's a lot of words and complication, and this is that's part of our charge is to really understand what's happening. So I very much appreciate the discussion. So thank you.
Thank you.
So I just want to, in response to what you were saying, tell you kind of the way I'm looking at the big picture here. With most pharmaceuticals that go through clinical trials, there are hundreds of clinical studies to get the data together to validate that there's safety and efficacy of the drugs in general, and that physicians know that before they order it, right? A huge distinction in this scenario to me is that these specialty medications don't have all the rich data pool to demonstrate the efficacy component. But I think there are experts that look at this and believe that these are probably efficacious. And when we looked at that process where there's a couple of safety checks in there and a couple of reviews, it seems to me like between the physician and the pharmacists and the other board, that in the aggregate, they're attempting to address both the safety and the efficacy thing with a lot less data than the rest of the prescription drug industry has. And so my sense is that there is an effort to make sure that the patient is getting the best thing that we think that they can get. And to the other point that's sort of lurking in background is that we know these biologics are coming. And the sort of the fine tuning of these drugs to even, more narrow scenarios is going to drive these costs way up. And so I do think part of our charter is to make sure that we, like you said earlier, and just to verify that I agree with you completely, is that we really need to figure out how to make this so simple and so transparent that the public understands it, because they don't yet see that Medicaid wants to start handing out $100 million new bills to pay for biologics. And so all of this has to be good and competent.
Oh,
Yeah, Representative Merchant, I know if you have no more questions for Mr. Garcia, Heidi Cole representing AHIP has some input on this subject. I don't know if you let her in, or she doesn't seem to have a way to raise the hand.
Do you want me to elevate her?
Sure. Can we do that during public comment?
Sure. I mean, it's your meeting.
Hold up the public comments. Yeah, for the public.
Okay.
So we can do it public at one time. And
Sure.
Yeah, Mr. Chairman, if I also can get a moment.
Yeah.
I believe with the biosimilars and the biologics, I think what's lacking at the national level is the head-to-head competition studies. Those biologics that are coming out, we're not really seeing them compared to other biologics that are on the market as much as we used to with other older products. And so I think at the national level, that needs to be there so that we can make those decisions a little bit better. And when I say we, there are P&T committees behind the scenes that are looking at what drugs are covered based on the studies and the data that is available. I mean, data is coming out every 72 days and it's doubling every 72 days. So there's a lot of data out there, but I do believe that there's some of it that's still lacking from the drug manufacturers.
If I could, one interesting concept that was shared from the folks in the Mayo Clinic. And what they were talking about, it sort of caught my attention. If you look at the generics in the generic marketplace, we don't try to micromanage the price. We basically say, this is the maximum allowable cost, this is what we're gonna pay you. And let the provider and the pharmacy at that point in time use the market to figure out what product they can buy that the FDA has approved to be interchangeable with that brand name product. But we set the cost, we don't get into trying to dictate what we're gonna do. If you use manufacturer A, you get this price, and B, you get this price, and C, you get this price. There's a cap to it. So the pharmacy or the people at that point in time can use whatever product as long as it's at that price or lower. In the biologics, with biosimilars coming down, why couldn't we not use the same concept where we say at that point in time, the maximum allowable cost for this group of biosimilars, which are all basically interchangeable with each other. If you look at the European market, that's kind of what they have determined. And at that point in time, say, if you look at Humira, which is $3,300 versus a couple of the generic, which is $600, why not, as a market, say the maximum allowable cost for a Humira-like product is $800? What are your thoughts on just creating a cap on what is going to be reimbursed and paid for by the insurance company, the insurance industry, versus just getting into saying, we'll pay this much for this one and that one, because as far as the FDA is concerned, they're all interchangeable.
I'm sorry, Mr. Chairman, is that question directed to me?
Yeah, where's PCMA on that?
I mean, I think that's a great question. You know, I think what you've described as competition at its best, right, is the more products that come out on the market, the lower the price is. And that's where we see that with generics, as generic products come out and there's, you know, hundreds of manufacturers that make that. And we're starting to see that with Humira as well. Humira was the blockbuster drug. There was a lot of ways that they circumvented that patent to extend another 5 years and make billions of dollars. And now the biosimilars are coming onto the market, and we're starting to see Humira come down a little bit on price, or they're offering more rebates, or however they're trying to keep their market share. And that's the free market and competition working. I think in terms of the insurance and the maximum allowable cost, you probably see some of those bills come through in a few states where, you know, you can only pay a certain amount for a drug. And I think there's a lot of research there that needs to be done still of whether that's the right process or not. I don't think that there's any problems with limiting the cost of the drug itself versus limiting what the patient is paying. Because if you're limiting what the patient is paying from a copay cap, the drug is still going to continue on the other end from the premiums and the insurance side. There's no cost to that drug. And I believe what you're saying is cost of the drug itself, and I would agree with that.
Thank you, because that's one of the things when I look, the key word to use the free market. When you get into the free market, let the market work, the invisible hand. I think when you set a price point or cost, if you will, and that's what you want for reimbursement, let the market determine how to get to that cost factor. So thank you.
Mr. Chair, may I ask a question on that?
Please.
With regard to the biologics and the biosimilar equivalents, is my understanding that the biosimilars are branded? Is that a branded market?
Products.
I think that the economics there is, you know, this marginal cost difference between small molecule drugs and generics is a big difference in cost there. But you don't see that same difference between biologics and biosimilars.
There is quite, because if you look at Humira itself, it's $3,300. Look for one of the other ones, the market is cost plus, it's $600. 85% discount.
We did not see that in our analysis using the Remicade analysis because the other drugs were all branded.
It just started.
It's starting, yeah. So I agree with you in your statement about, you know, having a finite fixed cap on some of those drugs and the biosimilars. But I think the branding part is not to be overlooked. That was a major factor, you know, driving the absence of the marginal cost difference.
You have also in small molecules, you also have different brands of the same product.
Right.
So we have the same concept.
We see in our high cost prescription drug dashboard, when a drug goes generic, there's 7 or 8 different manufacturers that they seem to just specialize in just that. And they report these high cost drugs. They're all the same drug, but they have multiple non-branded competitors.
And take, we're trying to get to, if we can, Vincent, is that what we see in the small molecule market, because it allows for the market to work the way it should, is how do we learn from that side of the equation, bring it forward to biologics?
They see it like that way.
All right,
May I?
Yeah.
In the last part of the conversation, there was a lot of use of words like, we should set costs, we should let the market determine the cost structures and how things need to be getting paid. And it just felt to me like there's some language in there that probably could be cleaned up about what government does. When government sets a price, that's not the market, that's the government using a mandate. And I just want to make sure we're not implying that.
no,
Okay.
clear. What I'm saying is.
This is why I was a little uncomfortable with.
Clarify, what I'm talking about is not what the price is. They can set the price that they want. It's what the government's gonna pay for.
Okay, so you're still thinking that part of what we're going to be doing here
It could
is
be a
to,
recommendation saying, correct. Now, if you have Humira, which is $3,300, you have another one, $600, maybe our recommendation is that a reasonable reimbursement for that product is $800 to $1,000.
okay, I think we need to go back to the statute. I think it's what, 126, where it lays out there very specifically in the first paragraph what our authority is.
We're not saying
I don't even think
it's a
we have the
recommendation, but-
authority to make a recommendation.
Yeah, our job is absolutely to recommend cost transparency.
Yes, cost
Absolutely.
Strategies.
It's predominantly price transparency.
Transparency in the whole process so that people can make informed decisions and public payers can make informed decisions about how we're
You're
spending.
probably
public
right.
dollars.
It's
I am
been a
right.
while
Yeah,
since I've looked at it.
yeah, we
but
can look at the
Could
statute.
we add to the agenda, the pulling out of that paragraph that
Sure.
has our charter?
Sure.
Just to make sure, we're all back on the same sheet.
All we can do is recommendation. We can't.
Yeah.
Strategies, which is recommendations.
It is a fair point, and others have raised it prior to you to say, look, you're not setting price. You've got to be clear about that. We know that. And so your comment about language is really important, but that is not what we're all well aware of that. I surely.
I'm not, so maybe we could take a few minutes to just go over it again.
Yeah, absolutely.
Sure.
It's a fair point.
Fair point. Well, I think one of the other things we need to start talking about, and Mr. Garcia, we're all done with your presentation, but if you want to hang around for this lively discussion, by all means, stay. But part of it, I think also where's this fact is that when you talk about drug affordability, affordable to whom? Are we talking about the insurance company and the premiums? We're talking about the patient co-pays and so forth. Who is the audience that we're trying to focus our attention on? Because I think that's really critical to the mission of this board, defining affordability.
Again, in the first paragraph of the statute, doesn't it say that our job is to provide price transparency services to government payers in New Hampshire? I don't know why I'm thinking that it says that. But that's who the affordability is meant for, is who we're supposed to provide the price transparency to, which is other government payers,
Public payers.
public payers. All right, you guys can keep going. You don't need to watch my lips.
And incidentally, I mean, if you think about the largest employer, I think in the entire state, if you put them all together, it's the public payers. So let's not have any misunderstanding. The impact for Granite Staters is huge for public payers. If you think about all the people, it is by far, I think, if you look at all the university systems, the county government, state governments, by far the largest employer in the state.
Yeah.
So it matters to these people.
My goal isn't to minimize what we're doing. My goal is to clarify and make sure that we stay within the law.
Yeah.
That's all.
And my goal is to make sure that we do the same and that we discharge our job as people ask us to do and expect us to do. So it's a fair point.
All right. Moving on. Mr. Garcia, I want to say thank you. By all means, like I said, if you wish to stay around and listen to this Board conversation, by all means, stay on the Zoom if you wish to do something else more enlightening, if you will, by all means, understand if you decide to jump off. Thank you.
Thank you, Mr. Chairman. Appreciate it.
Thank you.
Moving on, one of the things I'd like to do for the agendas going forward is to put in front of the board and remind us of what the goals are for 2024, and they were in our annual report. So one of those goals was the advisory council. I think Mr. Williamson talked about that earlier, about working with Dr. Sherman. So do you want to, Mr. Williamson, if you want to give us an update, or Dr. Sherman wants to give us an update on where we're doing with the advisory council?
Yeah, the next steps, Tom and I will be drafting letters that will go out to each entity that is defined in the legislation. There should be a list in there, and we'd like to have that in place, or have the council in place over the next few months. Tom, do you have anything else you'd like to share?
I think Dr. Sherman dropped off.
Oh,
A little bit
well, he has
ago.
nothing to share.
Can I ask a question?
Sure, of course.
So, yeah, is it gonna be any opportunity for the board to review the composition of that?
Absolutely.
And to find out?
Absolutely, and as we get applications or nominations, we would welcome your feedback on those individuals. But it is, I'll remind everybody, it's fairly prescriptive. It will say, you know, someone from a hospital would define a hospital system and needs to be CEO or their designee, or the commissioner or their designee. So we can't be overly flexible, but we definitely want your opinion.
Was it within the purview of the board to nominate individuals?
None of the advisory council, no.
It's pretty, if you look at the statutes, it's very prescriptive. It's lists the agencies, normally it's the head of the agency or their designee. So it's really up to the head to designate who they want, if they don't want to be there.
Are there industry, members from
Yes.
industry? So in those areas, how were those ascertained?
That's a good question. If it was, if it says manufacturer, we would need to identify a New Hampshire manufacturer.
And is that board gonna do that
Um,
holistically, or is that gonna be done else?
If the most efficient way is by everybody weighing in, then absolutely.
Well, efficient versus appropriate, right?
Sure, yeah. I think again, first day. My intention is for this to be a collaborative effort. I also don't want to waste everybody's time if things can be done. If you want a list of manufacturers or a list of hospital systems that we may be thinking about and you would like to weigh in, I'm more than happy to send that around before we send out the letters.
Like to ensure that it's fair and equitable, and
Absolutely,
transparent process.
absolutely.
Thank you.
If you go back,
To the statute.
yep, 126 BB
Thank you.
for advisory council, it's very prescriptive. The governor or designee, commissioner of the Department of Administrative Services or designee, commissioner of the Department of Correction or designee, commissioner of the Department of Health and Human Services or designee, attorney general or designee. Records, it's very, literally, there's not much more. The board doesn't really get, if I look at this, if I listen to what you have to say as well, just because as I read it here, we don't have a choice who's gonna be on the board of the council. So thank you.
No, I appreciate that.
Then to your point, whether you can accept or reject somebody who's been delegated by an individual here, I think it's really kind of up to them. We could probably ask for a conflict of interest, somebody to say that person should be on the council. I think that point we could weigh in and say at that point in time, yes, we see that you designated so-and-so to do it, but we believe that person may have a conflict that would be an issue.
So is this letter that you're anticipating simply a sort of an announcement of the opportunity and that we're looking for these folks to come forward? And I do think, to your point, I think everything we do needs to be fully under the light of day, every single thing. Put it out there, and we can disagree vigorously, and I hope we do. But at the end of the day, let us do our job and let's be proud of it. This is really important for the people of New Hampshire. People are being crushed in these situations, and I think we need to really bring that same sunshine that we're going to impose upon ourselves to all of this. So
And
thank you.
we can absolutely do an announcement, some sort of press release to let everyone know that we will begin the process or that they should expect these letters to come soon. And then we will, after that time, send the letters out.
So that's just generally good practice, right? You know, if you're gonna do something important, you give people a heads up that something's about to happen. Just, you know,
It's why the same thing, I have been a staunch supporter of President Edwards, that these meetings are televised through Zoom. Technically, we're not required to, but I always say at the same time, these are public meetings here,
yeah,
but the Zoom is not something. So what I want to be sure of is, again, if we're asking for people to be transparent,
yeah, we gotta be.
then we have to be
transparent.
transparent. Okay, we have to hold ourselves to the same standard we expect them to be held to.
I agree with your Zoom decision, by the way.
All right, Senator Abbas, let's see, the redundancy report, Jason, where are we with that? I have not, the reason I asked the question is, I have not had any, inquiries from maybe somebody else on the board's had them, from the insurance department about collaboration, so I'm trying to figure out where we are with it.
Well, I've sought opportunities to speak in the fall at the meetings
Yeah.
that they were taken up. So since the passing of House Bill 2, it's clearly specified in there what the requirements are and the parameters to report on there. So at that point, I created a functional framework, essentially an outline, and built on it. How much time do we have in today's meeting to talk about that? Because we have a preliminary draft ready, sans integration, with the coordination with the PDAP part, and then presumably Mr. Williamson is going to play a direct role in helping to inform that report. So we do have, I know Representative Edwards is concerned about that, and it's not developed yet. Recall that the missive in House Bill 2 explicitly stated that it was due on or before October 1st of 2024. So I think we're in good shape to have it well before that, but that requires maybe some deliberation here by the board. So I was hoping today to describe, the functional form that this report has taken on from our lens, and I welcome feedback and strong and tight coordination and integration with this board, with Mr. Williamson. And
We can verbally,
yeah,
but we can't, there's no documents, because those have to be posted by.
so our commissioner has in his hands a preliminary draft that's not purviewed to the public because of the 91A right to know request. And so it should be ready soon, but we need to collaborate. Now we're fortunate enough to have our executive director here that could work on that, and other members of the board who, I openly would accept their feedback and integration on that. We don't want it to say just what Jason has or New Hampshire Insurance Department wants to say, rather a holistic viewpoint on this concept or construct of redundancies. And I appreciate the language in House Bill 2 in guiding that, because I've had to refer back to that much. So in that vein, I've framed it to look at redundancies essentially across a continuum, not categorically redundancy yes versus redundancy no, because it's not that simple. So to what extent in each of these areas of the statutory authority of this board are there redundancies and or are there novelties? And that's, I think, the output of this report should help inform the reader on just that and ways to improve the efficiency and economy of the work that we do, which was the spirit, I think, of the language in House Bill 2. So I stratified that by 3 areas. And the areas tend to relate to the different parts of the different sections of the statute that give this board authority. And it lends to this really more, the lens of transparency more than price setting and regulatory authority. So the price transparency part, I made a list of several things that the insurance department already does with regards to price transparency. I could show on the screen here, if we wanted to toggle to the insurance department's website, examples of 4 prescription drug reporting dashboards, prescription drug reporting requirements that we already do using the claims data that are explicitly stated in some of the statutes under 126BB that are already under repeal for the next 2 years. So that's a great example of some existing redundancies. Whereas there are other elements in the statute for really thoughtful reporting requirements that we don't currently do, that there's merit in pointing out that those are not redundancies. So that's just one set of examples that demonstrate that it's not just dichotomous, redundancy yes, redundancy no, rather across a long list of prescription drug data collection and reporting requirements. There's so many complexities that there are some redundancies and some outliers, and we need to point those out so we can do a better job and maybe draft legislation or recommend the drafting of legislation that helps to address those gaps. And I think that those are the efficiency and economy improvements that the spirit of the language in House Bill 2 was getting at. And it aligns with what Mr. Fahey was just talking about, Representative Edwards too. So that's what I've got so far. We are not far away from having a final draft, but we need the board's integration. So I'm recommending that prior to next meeting, I deliver a draft to all board members, including Mr. Williamson, for review so that we can really roll up our sleeves and start working on it.
How much time do you think we should put aside on the agenda for reviewing the draft?
That
I mean,
will
it's nice to have-
depend, that will
nice to have it ahead
depend
of
on
time.
harmony, that will depend
Yeah.
on the harmonization among the group, because I feel like, indeed, we're all aware of how contentious this issue is and how important it is too for our citizens. It's a really important thing, and while opinions vary, my sense is to achieve the spirit of House Bill 2, the language in House Bill 2 that has us making this redundancy elimination report to improve efficiencies and economies. So that, I think, puts the responsibility in our lap to find the common grounds, the things that we think about right now with regards to price transparency, which is what the statute says. Right now, what should we be doing? And then, we're obviously just at the beginning of this year's legislative cycle, so there is a lot of time from then until next legislative cycle for any types of legislative change that may spawn from the recommendations that are in the last part of this report. So legislative change could come in the following legislative cycle. So that's where I sit on it. I welcome feedback on it.
So is the guy here who screwed up HB2 the most, because I had the opportunity to. I will point out that at the end, I was juggling like 350 paragraphs for HB2. And I lost track a little bit of the PDAB paragraph. An earlier version of the PDAB paragraph, as I recalled it, made it a little bit broader on where we might want to look at redundancies. We wanted to look at redundancies with like the director of administrative services and the reverse buyback, and we wanted to take a look at what CMS was already collecting. And I think what happened was that language got constricted too much to say we wanted to look at the redundancy between the PDAB and the Department of Insurance, which is necessary, but never did I think it was sufficient. I don't know anyone who thought that was sufficient. So the reason I've been obsessed at looking at your paper is I would like to look to see exactly what is in and what is out of the redundancy report. If it's just the Department of Insurance and PDAB, I'm going to be disappointed, but I have no one to blame but myself. The other thing is we said October 1 of 24, which kind of made sense when you were just spitballing things. But now, as I sit here thinking through what this report needs to do, is it needs to be the rationale. Should we look at the construct of the PDAB and say, because of these redundancies, these gaps and these overlaps, both gaps and overlaps, we want to modify the structure of the PDAB, right? And that legislation probably needs to start getting drafted in August so that the stakeholders, especially Representative Merchant, get the stakeholders involved in like August to make sure that Okay, you said there's been contention. I actually see it a little bit different. I don't think when we've gotten to a very specific item and we've had something specific to look at and talk about, I haven't seen any contention. Where I've seen contention is sort of the lack of complete communication and uncertainty where people are going and what the motivations are. But when we've gotten to black and white, I think there's not been contention. So I think when we can get a report that we believe is objective and academic and useful, I don't see much contention, but I do see an opportunity to start figuring out, what is the implication of this redundancy, the gaps and the overlaps with the future structure of the PDAP. That's where I'm coming from.
Well, I think you'll be pleased when you see the draft of the report. And I think that if you want the onset of the start of legislative, endeavors to be August, I think we're in good shape. It's January now, and we could have something for next meeting. And
What is our authority to accelerate that deadline that's in the statute? Can we set our own internal deadline?
It says on or before, and
I think, yes, deadline is October 1.
Commissioner Betancourt is right on board with getting that out sooner than later. So there's really not any, if you feel like you think that I'm dragging my feet, that's not true. I've been working on this. I think it's just, let's get it on our lap.
I have tremendous respect for you. I'm just looking at the legislative calendar going, geez, 1 October is late.
The report's very well developed. I think you'll be pleased with what it says. Haven't heard your.
Before I could say yes or no about how fast we can go, I think we just need to see a draft first. I'm sort of not sure.
Yeah.
So I think for the February February meeting during school vacation, we'll have a robust conversation, begin to get a feel for it. This is the work that you're doing. So I want to say thank you and down that road and working with Mr. Williamson. But I think it's important to do it correctly and not do it expeditiously. I'd rather have it wait until the 1st of October and have a really good, robust report that can guide legislative thought than to try to rush something through and we don't think it through all the way. If that makes sense.
Expecting you've already anticipated this in your report, knowing how you write and think. Will you have a definition of redundancy at the outset?
Yeah.
2 of them.
I try to operationalize the concept of redundancy, because I think we think of it categorically: redundant, yes; redundant, no. Whereas this is to what extent, and I like us all to think like this: to what extent there are redundancies, because it's such a broad and complex topic and subject and set of topics that you just can't encapsulate that with this dichotomy.
Right, and in the spirit of this discussion, and you can have something could qualify as a redundancy if it hits like a 0.5% of it does 0.5% of what another thing does 100% of it. That's a redundancy. It may not be a very strong one,
Sure.
but it still satisfies that criteria. So I'll be curious to see that definition.
Let me give you an example just real quickly, so that there's one statute, part of 126 BB, that has 3 reporting requirements, A, B, and C. Well, C, for example, is a reporting requirement that the New Hampshire Insurance Department already gets from drug manufacturers. So of those 3, only one of them is redundant. So we're not going to assign a quantitative value. 33% is redundant, right? Because that's just on one domain of the several different price transparency responsibilities that this board has. I think there are a few gaps that, Representative Edwards brought up with the federal government. We talked about the CMSRXDC right now. As the language stands in House Bill 2, it instructs us to work in collaboration with the PDAB to examine redundancies among those 2 entities, those 2 agencies. But there's also some federal government drug data reporting responsibilities that the insurance department already reports on our website. We have these great dashboards that already report this information. That should be ingrained in the statute as well, but not to be redundant. As a state agency who has regulatory authority for some of these entities who are required to submit data to the state of New Hampshire, that's probably where the authority to collect that data should rest. And to that end, I envision the insurance department as being a repository of lots of data from different sources, whilst at the same time, protecting the economic well-being of the citizens.
And I remember when, even before you joined the board, that was a input you've given, that there's other reporting channels and there are repositories for that information. So, yeah, I'm looking forward to your report. Thank you so much.
Thank you so much.
And it's interesting because one of the things that's a goal, I didn't put it on here because I wasn't sure who was actually going to be here today. One of the goals was to understand what data does the board need to do its work. That's the first thing. And then where do we get that data? Is it coming from the insurance department, come from CMS? We need to have understanding to meet our mission. What's the data we need to get there? And then number two, do we have access to that data? So those are two things that I think we talked with you and Bob on, was trying to figure out what's the data we need and do we have access to it to get our work done. So I think to your point, Jason, I'm trying to get to is where the data resides is not so critical as having access to it. So as far as the legislative updates, I want to go, we have 3 bills that this board is impacted by. One was the conflict of interest. And Senator Abbas, I wanted to say thank you, by the way. What the committee talked about was if there's a conflict that can't be resolved between the board's review of a potential conflict of interest, that an arbitrator would be an attorney. Now, I talked about before having the attorney general be the arbitrator. And what the committee thought was probably more logical was an attorney appointed by the attorney general. Are you okay with that kind of language saying if the attorney general appoints an attorney to review, become the arbitrator, would that work?
It could. I guess my question is, with conflict of interest, they're usually very self-evident. And I guess I'm finding it hard to believe that someone with a conflict would take it that far. But I guess there needs to be a process in place for that.
So as the bill sponsor, Senator, can I just make sure you know the background? The background on this is pretty simple, actually, far simpler than where we're already at with this legislation. And that is to say that the board, the PDAB, is told not to have any conflict of interests. But when you go to the statute, there's absolutely nothing in there on how to deal with a conflict of interest that a board member doesn't choose to voluntarily resign. There's no way to compel a board member to vacate their seat and have somebody else appointed. And so without wanting to solve that problem, I put legislation in to say, hey, here's a problem, here's a way to fix it. Let's use the committee process to figure out a better way to do it. And I think that's where the PDAB has been in the last month or two, is just talking about different ways of how to address a problem we all think is real. How do you compel somebody to leave if they have a conflict of interest?
I got no problem with that, and correct me if I'm wrong, I don't recall if the language is in any of the proposed legislation, but perhaps if it's discussed by the board first, the board can all vote on it. It's a non-binding vote. I know some local zoning boards and planning boards do the same. It's not binding, but you may be able to persuade someone who may not think they have a conflict. If they say, then agree with the board, maybe I do, it might save us the time of having the problem go forward. If that doesn't resolve the problem, then I think the procedure that was described sounds workable. So that's fine. But again, whenever there's a conflict, it's something that I would like to think is pretty straightforward. So you might be able to convince that person to go their separate way, if that's the case.
So Dr. Sherman wrote some draft language in December that I promised him I'd look at that I haven't looked at yet. So I'll go resurrect that and reshare it through the chair.
And I'll try, the bill was heard by Commerce. So that's where it's at today. There may be a subcommittee of Commerce one of the things that was talked about at that meeting during the hearing was that instead of it being, quote, reviewed by the Attorney General, which is kind of like investigatory, and it doesn't look good by somebody having one review by the Attorney General.
Right.
The thought was that it would be an attorney appointed by the Attorney General. So you're not really reviewed by the Attorney General, but there's a third party that's neutral.
Yeah, I have no interest below the topic I just described.
Okay.
I just want us to have a way to make sure that the board's integrity is maintained over the long run.
And I think when I get the language back with amendment, I'll be more than glad to share with you and everyone else on the board.
All right,
Okay, if that works.
it's fine.
Right. The other one was House Bill 1601 that's dealing with the 2 to 4 years. I wanted to eliminate the restriction, or what we have now is 2 years on the executive director to extend it. Initially wanted to delete it completely. And based upon our conversation, we said we'll go to 4 years. And that's what's in the bill now. The other one was the question about contracts going to the fiscal committee. I did talk with LBA. It's very unusual for that to happen. It's not state standard. So
this is another one where I thought I recognized an issue with not having the legislature in the loop on spending. I think that's a constitutional obligation of the legislature to be in the loop on spending issues. And so I was asking the question, what's the right way to do this? And it's another example of me not knowing the right answer, other than knowing Constitution says the legislature is supposed to be in the loop.
and my understanding is, absolutely to your point, legislator controls the money that goes to an agency. So once it goes to the agency, you put parameters about how they spend it, but not getting down to the contract by contract.
The issue there is the agency, the PDAB is too independent of the agency. The PDAB was set up to operate largely outside of the control of the agency that it was appointed to, and that it was just a perform a review, which is not enough.
But I'm trying to figure out how to achieve what you're trying to get to, but
Yeah.
not have what I call constitutional overreach. That's the concern people have, is that
Hard to do that with the legislature being in charge of spending.
we'll have a review.
Yeah.
Okay, because it's not, according to what I've been told, it's not a state standard.
And well, we'll make one, but the other part of it is, the PDAB was set up to where we had an unlimited ability to find private entities.
That's not,
If that, no, that was true.
but it was. But we
It was
did-
true.
But that was struck.
And that got nicked in HB2, but I don't recall if that's gonna come back if we don't renew HB2. So the issue of
All right,
revenue and spending is still very much in the mix.
I hear where you're coming from.
Okay,
So, but that's where we are now with this bill.
Okay.
I want to keep the board up to speed to what's happening, so you don't have any surprises, someone come back and saying, this is what I heard, representative merchant and so forth. The other one was the biological, HB 1365. And that bill is also in front of Commerce. And we're looking for at that point in time is that if you have a biologic like Humira, which is $3,300, and you have another drug, which is drug B, that's $1,200, and you have another drug, it's drug C, and the FDA has said you can interchange, they have the studies switch back and forth between A and B and A and C. That therefore B and C are themselves interchangeable, because what will happen is we don't use the marketplace the way it's created. If I get a prescription for drug B at $1,200, my only option right now is to give you the $3,300 one. I can't give you the $600. Even though the FDA has said you can go from A to B and go from A to C. You switch them back and forth as much as you want to. They're safe, same efficacy. I was trying to get to allow the market to say, okay, if someone comes in with 2 point, Jason, it's a brand. So B is a brand too. So at that point in time, as a pharmacist, I want to be able to work with the patient and say to you, oh, by the way, there's drug C, which is half the price of what you're paying now.
Is cost the only factor under consideration in that, given the FDA's definition of interchangeability?
it's not cost, it's based upon the efficacy of the product clinically and safety of the
Right,
product.
so they're established the same efficaciousness.
Yes.
And then, so the pharmacist can at the point of sale do the interchangeability.
Just like you would
based
generic.
on cost.
Well, that's one thing that Representative Hunt wants to be sure of, is that when that happens, it's going to be to reduce the cost of the patient.
But this is what's done currently with generics
Generic.
and for pharmacists, and this is just allowing pharmacists to say that you do have an option to take an interchangeable product that could be less price.
Yeah.
Based on your cost sharing, would you like to take this? But right now, they're restricted from even saying it.
Yes.
Right, right.
You know, this is simply just allowing the consumer to know there's a lower cost product available, achieves the same thing. Now, they may enjoy their branded product and they may not switch,
Right.
but this gives them the option to choose. lower
Yeah, and
cost.
my question, I guess, suppose it transcends beyond the branding and even the
Mhm,
equivalency part, like using insulin
mhm.
in insulin pumps. There are known generic insulins that are not really good for insulin pumps. They crystallize the cannula and things like that, yet they're interchangeable and patients suffer mightily. And that's just one example. So I know that's calling into question a different part of the system, the FDA assignment for interchangeability and biosimilarity. Yet that, you know, that's the limits of my knowledge there, but that's what my question centered around. Is cost the only factor to consider? Holding constant the fact that the decision for interchangeability is made by obviously the FDA, and I'm not challenging that, but.
I can share with you, I mean, concern, I mean, there are times in which, I'll give you an example, in a generic world. I know patients who are allergic to blue dye or red dye, okay? And sometimes when you go to make a substitution, if it's on the profile, I know they have an allergy to one of the dyes, and I know that generic has it in it. So cost is not the only thing, looking at the safety factors of the patient themselves. I think that would come into play, the same thing with biologics. How are you using the drug? I mean, that's where a pharmacist has to work with the patient and understand how the drug is being applied, how the drug is being utilized, not just look at it from a cost point of view blindly.
That's, yeah, thank you for sharing.
Okay, if it helps.
Yes.
So that's where we are with the three bills today, 1601, 1225, and 1365. In regards to future meetings, we do have one scheduled for February 26th. That is school vacation week. So I don't know whether we're gonna have enough people here for a board meeting.
Must we have it that day? Because I have travel plans to Arizona. I can virtually call in, but I've never taken a vacation. I've never taken this 1 week of vacation.
Did you go to Greece?
That's a long story.
Long
But this,
story.
no, the school vacation.
Okay, school vacation.
No, the school vacation, I've never taken it.
Okay.
Can we like shift a day?
Well,
or
I have a speaker for the 26th. If they can move it, I'll be glad to make the move if we can, but I don't know at this point in time who will be here on the 26th.
I won't be
You
here
won't be here.
physically.
You won't be here.
I will be drinking a gin and tonic wherever I'm at.
Well, if you're in Arizona, it's 7:30, so you're okay.
It'd be like 6 in the
You
morning.
think that's a problem? Maybe a bloody mary.
So I committed to a speaking obligation already at 10:30 that same day. Also, I have two young kids, so if one of them will be home. One of them's in school already, so they'll be home. So I'm not going to guarantee my appearance, but I'll just put that out there.
All right, thank you, Senator
I'm
Davis.
planning on me not attending, but if things change quick sometimes.
Jason,
I'm available. Yeah.
you okay?
Yep.
You know,
I've never been on a vacation either. My kids are in college.
No,
One of them.
so no more.
I don't want to suck them on stuff.
And I think, Bob, where are you on that day? Are you gonna be back from your surgery, maybe on Zoom or?
No, I'm back from the surgery today. It's the snow that's the problem.
Oh, okay. will you be available on February
Yes.
26th?
Yes,
Yes, okay. And I know we don't have Dr. Sherman and Senator Rosenwald, so we have enough for a quorum, so we'll continue down the road, 26th, fine. And the one after that will be, again, the fourth Monday of each month is what we set aside. Now, want to capture things for the meeting in February. You wanted to talk about the mission of the board.
I just wanted us to come back and all talk through it, make sure that we have a common vernacular and agreement to what we're saying that our mission is.
Jason, you have a draft on the redundancy report that we can go over?
Yeah, I get back to the office and talk to our major med lawyer and see what the process is, because there are some complexities with disclosing a report that, you know, if we disclose a report, it's made to the public, then it must be posted on our website. And so my question is to the board, disclosing the report to the board in its draft form, to what extent does that still apply to?
My understanding of 91A is it's covered. You got 10 days from the time you submit a draft for review before it has to be discoverable. That doesn't mean you have to put it on the website, but it means if somebody files a right to know request, you have to respond to it.
Okay, I appreciate that.
So you'll do that investigation, I guess?
Yeah, and given that, that gives us a window of time with the 7-day, 10-day rule to maybe distribute that 10 days prior to the next meeting. My hope was to do it sooner.
We have to do it at least 7 days.
Right. But, so once I send that out, within 10 days, it will be subject to the 91A request.
Subject, not mandated.
Oh,
Yeah, no,
well,
those things scare me because we have lawyers, you know, that we consult
Dear
with, our legal
lawyers.
counsel.
None of them are smarter than you.
Terrible.
But they're lawyers, and by that advent, I have to ask them, and they make those decisions and inform us data analysts and scientists, because we get really scared about those things. And
No.
so,
Just to be clear, though, if it's going to be a document shared in the public session with this board, it has to be in the board's website 7 days
Right.
before.
Yeah.
So,
Obviously, I'm not the insurance lawyer, but I generally just say, just keep the word draft on it and you can disclose it that way. That way it's still subject to change.
gotcha.
Right.
And I've done
All
that,
right.
so.
big
all
letters
right.
draft.
So I'm halfway to sitting for the bar.
That's
That was my way to lawyer.
But your lawyer, obviously, you should listen to
Well,
your
we
lawyer.
got
over
three
me.
of them here today. Get Senator Abbas up there too, so. All right. In regards to what else do we want for February 26th? I have a speaker coming. Hopefully we'll know tomorrow morning.
What speaker?
It's Antonio
Chia.
Giacca, who's a person that does a lot in this space with the whole pharmacy supply chain and trying to help us understand, to your point, what the process, who the players are. He has no skin in the game. He's just basically done a lot of work in this arena.
So if I were to throw out a request for a future guest,
Yeah.
I would ask for our colleagues in Maine to come give us an in-depth update on, you know, what they found with their law, because ours was identical at one point, and what their experiences are.
Yeah, absolutely.
Do we get to offer transportation requests or
We don't have a budget.
reimbursements? Well, we did have a budget. Somebody gave us a
I'd
budget.
be a contract, let's go. Sorry.
I'll go get them.
Anything, if you want speakers, anyone, please let me know. Be more than glad to coordinate them.
I know prior to my tenure here that you brought representatives from ICER in.
Yes,
And I am very interested in that, not just at a self-serving level, but I think that would probably be of interest to the board to, you know, start looking at, we use this term affordability, which has a nebulous and broad definition, really. You brought up a weakness of it, and I think there are many, and but this concept of cost utility of drugs, I think, is an important one. And I think that, you know, other nations who have more socialized healthcare systems really rest on that for drug approval, whereas I think that kind of a blended or hybrid approach for our country, there may be more of an appetite, if at all, one that balances free market and these important, decisions that individuals and their providers get to make, but also having our shared pooled risk, payers paying for drugs that really have highest utility, that are really saving lives, and adding quality of life and years of life. And I think that's an important frontier that interests me. And I know right here in Boston, we have ICER, and they're doing great work. And I would love other members of the board who aim to do great work too, to hear some of those messages. And I think Mr. Williamson nods his head in interest, because those are the things that we can do to have a meaningful improvement on our strong healthcare system and the lives of people that it serves.
Awesome. I agree with you. I think one of the things too is that Catalina Porta talked about that before with True Data RX.
Yeah.
And what she has is bubbles, if you will, at least what she showed me. And I think she shared it with you and Bob at the same time, was that you could have drugs looking at the efficacy of the drug, but then looking at the cost factor. You could have two drugs that have the same basic efficacy, but one's price-wise is 10 times the cost of that one. And I think it's helped, again, back to driving the board, is how do we use that information to disseminate to the public affairs and to anyone? These are opportunities to reduce your overall drug cost by looking at the data. Good. Bob?
I agree.
Okay.
So maybe, somebody may know this already, but I heard the other day from somebody who seemed credible that they said that it is prohibited by CMS rules for the state to consider cost of a drug a factor in having the drug reimbursed by the state. And that sounds so odd and bizarre to me. I'm wondering.
I think there's some truth to that, but I can find out.
Could you find out, please? Because now I'm nervous.
Yeah.
Because like we talked about, the biologics are just gonna be money expensive. We gotta.
Yeah, I can follow up with our Medicaid pharmacy folks here out Pega, Clifford, and at least for Rand.
Thank you.
Maybe has a question before me.
Bob? You have a question?
The restriction is in Medicare, I think, and Medicaid, not in general.
But as was pointed out earlier, Medicaid's a big part of the public payer mix, and that's a big part of the total mix, so.
If you're asking whether I agree in the rationality or the irrationality of that, I'm totally in favor of, classifying that as irrational. Not all things that get through the legislature, at least at the national level, are totally rational.
Good save.
This is pretty far down the list,
Yeah.
I think, but I do think that we need to figure out what the channels are for telling our story for the work of this board. And that might be a question for Mr. Williamson, but how do we get that information out? How do these reports get out so that they're seen by the people that need to see them? And then maybe some others who perhaps should see them, but wouldn't be looking for them?
Excellent point.
Or more broadly, kind of a marketing campaign of the key findings of this board. Like, should we be thinking about, a September 1 drug day where we get together and we make a big deal with press release or something? I mean, I would think that's part of what you're going to be thinking about. Absolutely. Is how do we do the PR piece of this?
Absolutely. You all mentioned individuals specifically. You mentioned like Sarah Amond at ICER. I heard colleagues from Maine, that could be Jennifer Reck at Nashby. Are there topics you would be interested in drilling down over the next few months?
I mean, with regards to the ICER, I want our board to understand cost utility of drugs, how it's measured, what it says, what it doesn't say. And examples in other nations that they use, and how some reflections of that may have utility in the United States, like the reference pricing. So maybe the United States doesn't have to start with HTAs, health technology assessments, which are the government frameworks used to identify cost utility and set benchmarks for approval of drugs based on a certain cost utility. So to understand that, to maybe glean their interest, I have my eyes on some areas that interest me, but I think that my colleagues who aim to do important work to help the citizens there may be merit in them understanding that some way, in their way.
Great.
So that's how I'm looking at it.
Great. And would you be interested in learning more about how Medicare is approaching negotiation, how they're conducting their own assessments? Would you be interested in that, or learning their process?
Yeah, I think that's probably down the line for this board, right?
Yeah.
Because I think cost utility is something that's very difficult, and it seems like ideologically at odds with free market and, you know, the free state of New Hampshire, and whereas I agree with that, I think that opening up eyes to that concept. We recall that, you know, we have these new GLP-1 agonists coming on in spades to a drugstore near you. And Morgan and I just did an analysis just in the Chiz. In 2022, the state spent over $50 million on semaglutide, presumably with the lion's share on, you know, the indication of type 2 diabetes, and now there's a much broader indication. You know, coming to a health club near you, and that, you know, in my background, physical activity epidemiologist, I have great concerns about that. Not the use of it, and making people leaner and healthier and stronger, but the cost that will incur to our already costly healthcare system, given that there are many well-established co-substitutes. So, and I'm not picking on that important drug. I'm identifying an imminent threat to the affordability of our entire healthcare system with regards to a specific drug that the United States has a very jaded, longstanding negative history with.
I think one of the things, if I heard it correctly, Jason, is that we could also look beyond our borders, what other organizations, other countries have done to try to make drugs more affordable. Back to utility.
And I'd like to, for the record, just state that, you know, by no means am I in favor or suggesting that the United States has a socialized healthcare system. That's the biggest argument when you bring that up, right? We have the greatest healthcare system in the world that depends upon the integration of these free market forces. And to Representative Edwards' point, you know, government's overreach in those industries is not what I seek. I seek a model that informs people about the cost utility of the many therapies to their avail, and not the government forcing any kind of structure. I want to think that's there. Thank you.
Great.
All right. Before I move on, so we have the meeting on February 26th. The other one will be March 25th. Those are the two meetings coming up. I'll work with Mr. Williamson on the agendas going forward. I'm so delighted to be able to say that. And also, the last is public comments. We've had some people before, I think. Heidi Kroll wanted to make some comments, so I don't know if there's anybody here in the audience that wants to make comments. Okay. Who's on the let's see.
Oh, there she is. Okay.
There's right there.
How do I elevate? How do I elevate Nancy?
You don't, I do, and she should be allowed to speak. You should be okay to speak, Heidi. I think you should be okay.
Yeah, good morning, everyone. Can you hear me okay?
Yes.
Hi, Heidi.
Good morning, everyone. My apologies for not being there in person. I'm home today on a snow day with my son. So thank you for giving me the opportunity to speak. So I just wanted to circle back to the conversation that was happening earlier around white bagging and give you a HIPS perspective. So, you know, the carrier's perspective. So we see white bagging as a very important market-based solution to provide an alternative to the buy and bill model. It's not that each and every carrier is 100% using white bagging, but it does provide an alternative in the case where hospitals and other providers are unwilling to negotiate on fair and affordable reimbursement levels. So there's plenty of literature out there around the markups on the clinician administered drugs. They are very significant. They are profit centers for providers and hospitals. There have been many studies have demonstrated that the buy and bill, model is a revenue maker, for the hospitals and other providers. And this is on top of the already very high drug prices that are set by the manufacturers. So as an example, there's a 2018 study by the Moran Company that found on average hospitals charge 479% of their cost for drugs, and this is nationwide. The study goes on to report that most hospitals, 83%, charge patients and insurers more than double their acquisition cost for medicine, marking up the medicines 200% or more. The majority of hospitals, 53%, mark up medicines between 200 and 4% on average. And a small share of hospitals, 1 in 6, which is 17%, charge 7 times the price of the medicine. And 1 out of every 12 hospitals, which is 8%, has an average charge markups greater than 1,000%. And I think as somebody mentioned, hospitals that participate in the federal 340B program charge on average nearly 400% of their costs for patients' cancer drugs. So, I just wanted to point that out. And we're seeing, many large hospital systems have their own in-house specialty pharmacies. So carriers look to outside or third-party independent specialty pharmacies as alternatives. All specialty pharmacies are nationally accredited by the same organizations, whether it's inside or outside of a hospital. They've, entering the marketplace specifically to deliver medications, safely and affordably to hospitals and other, healthcare facilities. So from our perspective, third-party specialty pharmacies are lowering patient healthcare cost by providing a safe and lower cost option. And those we're seeing meaningful results for employers, public payers, health insurance companies, patients, and taxpayers. I also wanted to say that thousands of patients are successfully and safely receiving their drugs through white bagging each and every year. It's important to note that, third-party specialty pharmacies are only used for certain prescription drugs that can be safely delivered through white bagging, and only when the patient is an appropriate candidate for such forms of dispensing. There was some question about kind of the reliability, so I don't have anything more. I'm sure there's something more recently, but the statistic I have is that in URAC's 2021 specialty pharmacy aggregate summary performance report, URAC is a national accreditation association. They report that 40.5 million specialty prescriptions were dispensed in the US in 2021. 99.98% of prescriptions were dispensed with no errors, and 99.95% of prescriptions were distributed with no errors. And again, all specialty pharmacies must abide by all state and federal legal and regulatory requirements, in addition to meeting, extra safety requirements for specialty drugs that are imposed by the FDA and by the drug manufacturers themselves. In addition to those extremely stringent safety requirements, health plans always do have exception processes in place to address the rare circumstances of quality, safety, medical necessity, care interruption, any of those sorts of things. So, patients are not left, waiting, care disruption, and they're also not being, charged twice. And so health plans, develop their specialty pharmacy programs with all potential dosing and treatment dispensing scenarios in mind. There was a question earlier about, maybe the dose needs to be lower or bigger. And I think, those considerations are taken into account when the medication is shipped from the specialty pharmacy. So that the dose can be adjusted as required at the time of administration. So I think in sum, my point was simply that from the carrier's perspective, we really see white bagging as a critical market-based tool to lowering the cost of physician-administered drugs. And I appreciate your giving me the time today, Mr. Chairman.
Thank you for that. Also, I want to share with for the board here, this is the JAMA Network opened, published in September 2023. The out-of-patient obligation for the patient went up by 216%. So I go back to the question, are we just cost shifting? Are we putting more burden on the patient versus the insurance company? So we're lowering what's going through the insurance company, but we're hitting the patient with 216% more out of pocket. Not saying we solve it today, but that's just one of the things I have concern on.
So I think Ms. Kroll just provided a lot of data. I'm wondering if she's able to provide that in a document form so we could add it as a supplement to the minutes. Would you be open to that?
I would be happy to do that, Representative Edwards. Yes.
The second part of that was adding it as a supplement to the minutes. That's the chair's discretion.
I don't know if we can do that, right? Because it's not, the document wasn't part of this hearing.
She just read it in the
Yeah,
hearing.
but we didn't see it. She's reading it. So, Ms. Kroll,
I would like it. I just don't know when we get it in.
I would say at this point in time, what I would suggest if you want to is send the documents to the board and we can review the documents, make them part of our meeting.
Sure, I'd be happy to send a letter addressed to the board, and that way
Yes.
information will be there and it will, happy
We
to
call
do
it old business next
We
meeting.
call it old business next time. Yeah. Put it under, I think the board needs to look at the actual documentation and so forth, not just the verbal part of it. And once we have the opportunity to look at the documents themselves, we can put it in minutes.
Cool.
Okay. All right. Anything else? Any other public comments before we go? No. Adjourn the meeting at 12:44. Thank you.
Thank you.
Nancy, what do I need to do?
Don't touch anything.
Hold on, I'm gonna stop recording.